My name is Mandy Owens, and I'm a licensed clinical psychologist and research scientist at the Alcohol and Drug Abuse Institute at the University of Washington. I'm going to be taking you through a 3-part training series on medications for opioid use disorder in Washington state jails. For the first part, I'm going to be providing a brief introduction to opioid use disorder and medications for opioid use disorder. So, what is opioid use disorder? Opioid use disorder is a serious, life-threatening health condition. Opioid use disorder is chaotic and can be destructive socially, such as interfering with relationships, psychologically interfering, such as worsening your mood, and also can be medically destructive, such as contributing or increasing risk of infectious disease like HIV and hepatitis C. Non-fatal overdoses happen to about 1 in 5 people who use heroin annually. Overdose deaths occur in 1 to 2% of people who use heroin annually. These are part of the opioid epidemic that the United States has been seeing over the last few decades. Opioid use disorder is particularly common and dangerous among those in the criminal legal system. Many people incarcerated in jail have opioid use disorder, and approximately 3/4 of people with opioid use disorder relapse, that is, return to drug use, within 3 months of their release. This time after release from incarceration is very high risk for opioid overdose. In fact, we know from a research study from the Washington State Department of Corrections that people being released from prison are 129 times more likely to die from a drug overdose in their first 2 weeks of release compared to the general population. And this is for many reasons. First, someone's tolerance for opioids go down during incarceration because they have little to no access to drugs. And 2, people often return to stressful environments where they have access to drugs again. And both of these things contribute to someone's increased risk for overdose after release. Opioid use disorder can include opioid withdrawal. Withdrawal can happen either when somebody is consuming something on a regular basis and their body gets used to having it. So when they no longer are taking in that substance, their body can experience withdrawal. So for example, if somebody is a regular coffee drinker and stops drinking coffee, they might experience things like headaches or sleepiness or be irritable. What this looks like for people with opioid use disorder who might be going through opioid withdrawal are they can experience things like increased heart rate, nausea and vomiting, diarrhea, sweating, restlessness, bone or muscle aches, runny nose or tearing, tremor or shakes, yawning, anxiety or irritability, or chills. It can be especially important for jail staff to recognize these symptoms so that they can alert nursing or medical staff. So for example, if somebody expresses that they are feeling achy and they're having diarrhea and having chills, this could be opioid withdrawal. And we know that people in jail settings might not always feel comfortable with disclosing the fact that they're going through opioid withdrawal for many reasons. Even though opioid withdrawal can be fatal. And I'll say that again, people can and have died from opioid withdrawal, including people dying from opioid withdrawal while in jail custody. So this diagram is another way to think about opioid use disorder. So on the left, you can see that people who begin using opioids, whether those are prescribed or illegal or both, they can eventually develop opioid dependence, which is a biological component of opioid disorder. And this includes things like tolerance and withdrawal, which I just talked about. It can also include this more disordered characteristics, such as social problems, including relationship problems, such as those with friends or family or spouses. It can also include problems with work or school, such as not showing up to work or feeling tired and not being able to perform properly. It also could be things like giving up activities in order to use drugs. People could also experience psychological consequences, such as cravings, persistent desires to cut down or quit using drugs, or using more drugs than they intended. Other symptoms of opioid use disorder include things like spending a lot of time using drugs, repeatedly using drugs in dangerous situations, such as driving, and using drugs despite physical or psychological problems, such as worsening of mental health disorders. Another way to think about opioid use disorder is with this graph. So on the left side, we see a range of feeling really bad at the bottom, to feeling in the normal range, to feeling really good at the top. And when people are new to use, they might start by feeling normal. They then might use and feel really good. So that's that first line on the graph. And then they go back down to feeling normal. And then maybe they use again and they go up to feeling really good, but maybe not quite as good as the first time that they used. And then they eventually go back down to the normal range. And you can start to see how this pattern, if it continues, can progress into disordered use, such that people no longer are using to feel really good, but eventually they might be using just to not feel really bad and to try to feel normal. So as people continue into their disordered use, they are on this up and down roller coaster, which can help characterize this chaotic lifestyle that we talked about earlier. And it makes sense why this would start to disrupt other parts of people's lives, such as their relationships or ability to work. This is where recovery with medications can come in. We have seen that when people start taking medications for opioid use disorder, they can come off of this chaotic roller coaster and start to experience some stability in their life. So rather than experiencing this up and down that can come from using opioids, when they start taking these prescribed medications regularly, they can start to feel more within that normal range on a consistent basis. Another way to think about the role of medications is by returning to this graph. So when someone takes buprenorphine or methadone, maybe with social support and counseling, you can really start to see the separation of biological dependence with these other disordered consequences, such as social and psychological problems. So in other words, when someone takes methadone or buprenorphine, they may still experience this biological dependence, but they may no longer experience problems with their family or cravings. There is now a separation between opioid dependence and opioid use disorder. And this is true for the clinical diagnosis as well. Someone who takes a prescribed opioid on a regular basis, such as methadone, buprenorphine, or any other opioid medication like for pain, they may be opioid dependent without meeting full criteria for an opioid use disorder. So next, I will talk about the 3 FDA-approved medications for the treatment of opioid use disorder. First, there is a lot of evidence for medications for opioid use disorder. Methadone and buprenorphine can lead to improved quality of life, reduced costs, reduced arrest, improved healthcare utilization, including infectious disease treatments such as HIV or hepatitis C, and decreased mortality and overdose. There is also initial evidence for a newer medication, which is long-acting injectable naltrexone or Vivitrol. So this is different than the oral form of naltrexone. However, we know from this injectable form of naltrexone, Vivitrol, initiation and retention rates are significantly lower compared to methadone and buprenorphine, which limits the benefits of this medication. On this slide, it's just a subset of research studies on the evidence for medications for opioid use disorder. What's less important than going through each of these studies is making a few points. First, the evidence is clear. Medications for opioid use disorder is the best treatment for opioid use disorder. We also know from research studies that talk therapy adds little to no benefit on top of medications. That's not to say that talk therapy should not be offered to clients or can't be helpful for clients. It's just saying that we know that medications are the best treatments and should be discussed based on the client's preferences. Next, I'm going to talk about each of the three medications. First is methadone. This is the medication that has been around the longest. It is a full opioid medication, or what we call a full agonist. What this means is that the more one takes, the more one feels the effects. Methadone manages cravings and withdrawal by binding to opioid receptors. It lasts about 24 hours and is taken by mouth, usually liquid. It's provided only at opioid treatment programs. It is generally given by daily observed dosing, and it requires regular urine drug testing and counseling. Now, for some clients, this daily observed dosing, regular urine drug testing, and counseling can be huge barriers for continuing and staying on methadone. Next is buprenorphine, or Suboxone is the brand name. This is a partial opioid medication or a partial agonist. What this means is that above a certain dose, one stops feeling more opioid effect. This is part of the reason why buprenorphine is such a safe medication. It means that above a certain dose, somebody no longer feels the opioid effects, which means that the body no longer experiences increasing respiratory depression, which is what slows down people's breathing and can contribute to opioid overdose. Buprenorphine manages cravings and withdrawal by binding to opioid receptors, similar to methadone. It lasts about 24 hours and usually taken by mouth, often under the tongue or sublingually. Although implant injections are also possible and are becoming increasingly more common. Buprenorphine can be prescribed by a medical provider and picked up at a pharmacy. The third medication is long-acting injectable naltrexone. Again, the oral form of naltrexone is not FDA approved for the treatment of opioid use disorder. Naltrexone is an opioid blocker. It is not an opioid. It can manage cravings for some people. In an injection form, it lasts about 28 days, although some clients may notice that it starts to decrease effectiveness sooner. Individuals should not use any opioids for 7 to 10 days before taking naltrexone, otherwise they might go into opioid withdrawal. Naltrexone is prescribed and administered by a medical provider who may require urine drug testing and counseling. Next, I'm going to talk about some common questions and concerns that people have had about medications for opioid use disorder. A common concern is that we are, quote unquote, replacing one drug for another by using medication for opioid use disorder, which is perpetuating addiction. Although this is an understandable concern, it's important to highlight the difference between dependence and use disorder. So to make this distinction, it might be helpful to go back to this graph, where we can see that by adding a medication such as methadone or buprenorphine, it really separates this biological dependence from the rest of the disorder where people may experience social and psychological problems associated with their opioid use. Again, when people are on medication, it can help get them off that roller coaster of disorder or chaos. Some other concerns that have come up with medications for opioid use disorder can include things like, I don't want to be on medication forever, or now I'm addicted to Suboxone, or what about counseling or support groups instead? And it can be helpful to consider these other ways, other frames of thinking. So when thinking about, I don't want to take a medication forever, it's important to remember that medications for opioid use disorder should be prescribed as long as they're helpful and no longer. This does not necessarily mean forever. Although we know from the research that the longer people are on medication for opioid use disorder, the better their outcomes. Now I'm addicted to Suboxone. Again, here it's important to remember the difference between dependence and disorder, so that although somebody might have a biological dependence, the addiction or disordered part of their opioid use may stop or go down while on medication. What about counseling or support groups? Since medications for opioid use disorder do not exclude participation in these modalities, it's important to remember that. Now, that is not to say that they shouldn't be offered or shouldn't be helpful or can't be helpful for people with opioid use disorder. It's just that we know from research that medications tend to have the best outcomes in terms of the treatment for opioid use disorder. Therefore, talk therapy should be explored based on the client's preferences. So in summary, opioid use disorder includes consequences to people's lives, including social and psychological problems. Medications for opioid use disorder are the best treatment for opioid use disorder. Talk therapy should be offered, but it should not be required. We know that for many clients, they can benefit from medications alone. There are 3 FDA-approved medications for the treatment of opioid use disorder, and they include methadone, buprenorphine, and injectable naltrexone. However, based on research, only methadone and buprenorphine have shown to reduce the risk of overdose and death. Now, that concludes the introduction to opioid use disorder and medications for opioid use disorder. For the next learning modules, part 2 will explore the role of medications for opioid use disorders in jails, where we will hear from Lieutenant Satt from Kitsap County Jail and Commander Saltemeyer from Franklin County Jail. In part 3, on common concerns related to medications for opioid use disorder in jails, we will again hear from Lieutenant Satt, and you'll also hear from somebody with 25 years of incarceration who is currently on a medication for opioid use disorder. And with that, we thank you for your attention and consideration of this information.